Welcome everyone to the She Can Fix It podcast, a monthly podcast consisting of interviews with female surgeons to highlight and empower the women of orthopedic surgery. I'm Alana, and I am a second-year orthopedic surgery resident at Yale. On this episode, we have a great interview with Dr. Antonia Chen. Dr. Chen is the Director of Research for the Division of Adult Reconstruction and Total Joint Arthroplasty in the Department of Orthopaedic Surgery at Brigham and Women's Hospital in Boston, Massachusetts. She specializes in hip and knee replacements. Additionally, Dr. Chen is an active clinician scientist. Her research interests include infection in total joint arthroplasty, pre-habilitation, opioid prescribing patterns in total joint arthroplasty, and joint stiffness. She is on numerous committees in prominent societies, including the Musculoskeletal Infection Society, the American Academy of Orthopaedic Surgeons, and the American Association of Hip and Knee Surgeons. She is also a part of multiple editorial boards for numerous orthopedic journals, including the Journal of Bone and Joint Infection, Knee Surgery, Sports Traumatology, Arthroscopy, Bone and Joint 360, and Healthcare Transformation. Dr. Chen is doing a lot for the field of orthopedic surgery, and it was an absolute pleasure to have the opportunity to speak with her. I hope you all enjoy my conversation with Dr. Antonia Chen. Dr. Chen, thank you so much for being on the podcast. I really appreciate you taking the time out of your busy schedule. So I was hoping first you can kind of introduce yourself to our listeners and kind of describe your background with regard to where you went to medical school, residency, fellowship, and all your post-fellowship years.
So my name is Antonia Chen. I was born and raised in the tiny state of Delaware, and subsequently I moved to New Jersey. And when I was in New Jersey, I went to undergrad up at Yale and then went to medical school back in New Jersey at Rutgers Medical School.
Nice.
I subsequently went to Pittsburgh after that for residency under Dr. Freddie Fu, and then went to a fellowship over at Philadelphia at Jefferson or Rothman Institute. I practiced there for a few years, and now I'm at Brigham and Women's Hospital in Boston.
Wow, well done. So you're an East Coast person for sure.
Through and through.
Through and through. How were your medical school and residency experiences? Is there anything that you kind of picked up kind of from each? Because you're not one of those people who kind of went to one institution and stayed there. Like, you went to many different institutions. Is there anything that you kind of picked up from each of the institutions and programs that you were a part of?
That's what I loved about moving to different places. You learn something new from different people, which is really nice. So when I was in medical school at Rutgers, I met my mentor there, who actually is the one who encouraged me to do joints. His name is Dr. Alfred Tria. He goes by Freddie Tria. And I decided my first year of medical school to go into orthopedics. I was originally going to do pediatrics. I like kids, and I thought it'd be a great situation, right?
Yeah.
Then I that when kids are sick or complaining, they can't tell you what hurts. They just cry. So not the easiest to fix. And I learned something about myself that I really like to fix things. Mm-hmm. So it's hard to fix diabetes. It's hard to fix hypertension. It's hard to fix chronic medical conditions. But you can fix someone with surgery. So I got really interested in surgery. And we were in an anatomy lab, and we would pull on, like the finger or the hand, and little things would move. And I was like, oh, that's really cool, right? Just function sort of thing. So my hand surgeon actually encouraged us to do orthopedics, and I ended up doing a research project with this guy over at Rutgers. And he was over at another hospital that was neighboring us, and he did knee replacements. And I saw patients not be able to walk. So that's one little thing I took from there. Probably a big thing because it influenced the rest of my life. Yes. But that made a pretty big impact, Wow. And then I went over to Pittsburgh, and Dr. Fu is a big sports guy. And he really told us about anatomy and how anatomy we have to emulate anatomy because that's what we were given in the first place. And by doing so, you can actually make patients or make people feel more natural. So that was really neat to learn from there. And then from Rothman Institute, one thing that they would really well is they do efficiency really well. So they take care of a lot of people in a very efficient manner and then take care of them well. And so I took that from there as well, too. So little things from every place.
Right. So it's very interesting with your story in that you first thought you were going into pediatrics. And I think I was actually the same where I thought peds. And I pretty much know, like, from peds to ortho, it's quite a jump. So it's amazing that you kind of chose that you wanted to fix things. Were there any female mentors when you were kind of starting your journey, or did you kind of experience that most of the mentors that you had were male surgeons?
I was lucky. I had a variety. I have to admit that people who were way above us did not have the same variety, I would say.
Right.
So I am not breaking any glass ceilings. The ones above us, like the Connors, the Christy Webbers, they're really breaking glass ceilings, which are awesome. And we can ride on their coattails, which is also nice. And they can also be our mentors as well. My biggest experience probably with a female mentor was when I was a third-year resident at Pittsburgh. I attended my very first American Association of Hip and Knee Surgeons, and it's very daunting. All these people are really magical at their field, all these people who you've heard about or read about, and you've never actually met them in your life. And I met a surgeon, Dr. Audrey Tsao there, and she was a joint surgeon. And she was also happened to be an Asian female, but you don't necessarily need to have that. But she was basically everything I wanted to be. And she was in charge of a membership committee. And she was like, hey, do you want to help out with it? And I was like, of course I want to help.
Of course.
Yeah, you're going to ask, you're talking to me?
Right, exactly.
You're looking around, you're like, who do you actually want to talk to? And so I was a resident member of there, and I was a third-year resident, pretty impressionable at that time, and she was great about it. She still is my mentor to this day. There's many other female mentors I would count as well, too. I'm part of this Women Orthopedic Global Outreach, I think we'll talk a little bit about later. But all those women are fabulous women, again, who have broken this glass ceiling before me. Mary O'Connor is an incredible woman to watch what she's risen through the ranks and done. And Christy Weber is our first female president, which is fantastic. So while there may not be direct mentorship because we're not in the exact same veins or the exact same committees or groups, I have a lot to learn from them and have learned a lot from them as well.
Right. Out of, and you talk about Mary O'Connor, and I'm here at Yale, and I'm very fortunate that we have, very strong female representation both in residency as well as in faculty. I was wondering if you could talk about your experiences in residency. Were there other female residents in your program, female attendings? Is that something that was, when you were looking at which residency programs to go to, was that something that was very important for you, or is that just something that kind of at the time you just kind of got what you got?
So it was interesting. When I was actually looking for residencies, that was of interest to me, but not a priority for me, I have to admit. That said, I did come from a program that had 0 female residents at the time.
Really?
And I thought it would be nice to have 1 female resident at least in the program, right? So when I received the match list of the people who got in the pit, there were 8 of us who matched there. And I kept looking at the list and be like, Diane has to be a boy's name. Sarah has to be a boy's name.
Right.
And I just pointed on the list, there were 5 out of 8 girls in my class.
No.
First time ever in Pittsburgh, had never happened before. Just by chance, we were a class of 5 out of 8 girls.
Wow, that's phenomenal.
It was fantastic. Dr. Fu really made a push for gender diversity, I would say. Right. In every class, there was at least 1 female in class. And, a match is a chance. I could have matched at Pitt. I could have matched somewhere else.
Right.
And I matched at my home institution where I wouldn't have any females who were residents. But that was something of interest to me. So I'm really glad that it worked out that way.
That's awesome. Over the course of your training, do you feel that there have been more women, or at least that you're able to see? Because I know that the numbers certainly show that we're slowly, kind of but surely increasing the number, not so much the percentage. But what have you kind of seen in the institution and programs that you have been a part of?
I've definitely seen it. And the best thing about it, I think, is just a culture of understanding. I remember one time as a resident, one of the attendings looked at me and goes like, sometimes the women work harder than the men. And I was like,
You said it.
But, right. So there's a recognition that women add a lot to the table, as well as men, as well as, racial diversity, everything. Right. Just a geographic diversity, everything like that really adds a lot to the table and just brings for a good group of individuals, and we work better as a team. So I think there's a huge recognition of that. And I think this is across not just medicine, thankfully, it's business, it's all different areas. Recognizing diversity of teams makes for better groups. Exactly. So I definitely have seen it. The number of female applicants is increased, I would say. And I think because people are starting to see more women in, let's say, faculty positions, and they're able to emulate them. And so definitely the residencies have increased, the residents have increased of females, and also faculty. I think whatever in the past, there was 2 schools of thinking. One is, I don't want to be an orthopedic surgeon because I'll be too busy and I won't be able to have a family. Right. Then you start seeing people who have families and then they're like, oh, I can do that. And 2 is academics. I feel like less women are interested in academics because there's a lot of rigor to, teaching, doing research, et cetera, et cetera. But again, more and more people who might be interested in it in the past may not want to do it because of the lifestyle balance.
Right.
And obviously they can balance lifestyle potentially. So seeing that, I get to see the Mary O'Connors, the Christy Webbers, who work their tail off, but at the same time can do things that are outside of work.
Yeah.
And so seeing that, you say, I too can do that, which is really nice.
No, I totally agree. Speaking of research, one of the very humbling parts about preparing for this interview was looking at your publications and the sheer number of publications. I think it was over like 150 publications that you've had, and I was just mind-boggling. And I was just wondering, just literally how is it that you were able to do everything, the residency, have a great life, do all the sorts of things inside and outside of medicine, and yet just have so many publications?
So sleep is optional. Don't recommend. That's probably not an example. So that's by far the worst thing about me. I don't sleep very much, and I get in a lot of trouble for that. That said, I am surrounded by good teams, and it makes a huge difference. So each one of those papers are not just written by me. They're written with other people as well, too, whether it be editing, idea generation, teamwork, and group together, or data gathering. It's been great just doing it. I, for whatever reason, every time I write a paper and I have to go through all the corrections and back and forth, you forget the end of the last one, and you do it again. So I just think the idea of research, at least what drives me to do research, is that we can move the target forward, right? It's not just doing the same thing over and over again. It's about studying something and changing what we do. That's the goal, is to make some practice changing research. Not all my research is practice changing, let's admit it. And that's true for everyone, right? But if we can move that needle to say, hey, this is why we do something, kind of justifying it, or what should we do differently to improve our patients? That's what drives me to keep doing it. So
awesome.
It's a drug that I keep going for.
Yeah, no, that's amazing. And you did mention that you are a joint surgeon. And I was wondering if you could talk about, I know you kind of mentioned the reason why you were kind of steered toward the subspecialty of joints is because of your mentor. Could you kind of go into more about your subspecialty choice of joint replacement surgery?
So I was exposed to it as a med student, but that said, once you hit residency, everything seems really interesting and really neat the time you do it. Same thing like medical school, right? I did psychiatry and I thought it was interesting. I knew I didn't want to do it for the rest of my life.
You're like, that's okay.
Yeah, I knew myself well enough to know that, right? But when I came to orthopedics, all of it was great. Like sports was great, hand was great, footing, everything was really interesting the first time you do it. What I really fell in love was with open surgery. So I knew a few things about myself. I knew I didn't like using loupes, and I knew I didn't like using microscopes. And I knew I didn't like to sit there and futz with fractures to get them within 0.5 millimeters. But that's personal. I knew that about myself. So I like open surgery. So I narrowed it down to spine and to joints. Those are my two favorite. And I love spine. And then I went to spine clinic.
You're just like, no.
Patients with leg pain would get cured, but back pain is really hard to cure. It's impossible to cure sometimes. So I went to joints clinic, and patients got cured of their arthritis, right? They could walk again. They can move like they couldn't before. So the patient population really what drove me to arthroplasty. As one of my mentors back at Pitt, Chick Yates used to say, he goes, I make grandma walk again. And that was a really cool thing, because you'd see literally someone hobble in, and then a few weeks later, post-op, they'd walk out. And that was really powerful. So I decided to do arthroplasty.
I do want to talk about what some critics will say about joint replacement surgery, and maybe you can kind of demystify these myths about joint reconstruction, and that, like, as women, many of the deterrents for young women going into orthopedic surgery is the fact that it's so physical. And joint surgery is one of those specialties, or subspecialties, I should say, in which you are literally moving a leg around and, as you're testing the components that you just placed in. And so I was wondering if you can kind of talk about how, as a female surgeon, you are able to do your job as a joint surgeon.
So I have to admit, once I became an attending, I worked out more than I did as a resident. Because I knew the buck stops with me, right? So you have to be strong enough to do stuff. But I think the key factor is when I was a resident, I thought I had to do everything on my own, right? I need to prove myself. I need to be the best at everything. And you still want to do a really good job, but it's okay to ask for help. So if I have a hip dislocation, I will literally turn to someone who looks like that has more muscle than I will and say, male or female, doesn't matter. And say, please help me. or two of you, please help me. And so when I built my operating room team too, I would have no problem now asking, hey, I'm going to hold this in place, but then you can hit it in because I want it in the right position, because that's what matters most.
Right.
So when it comes to those sort of things, I realized that one, you can work smarter, not necessarily harder. And two, it's okay to ask for help. So those are things that have kind of changed in my practice. I think a lot of arthroplasty surgeons, male and female, get a lot of joint problems, shoulder problems. People have rotator cuff, cervical spine, lumbar spine. We have a lot of aches and joint pains because we're standing up all the time. It's not like cancer where you're sitting down, right? Or foot and ankle where it's smaller, or peds where the lifting help is for a 20-pound kid. My lifting help is for a 300-pound person, right? So I still lift my own patients. I still do things like that, but I do ask for help.
Right.
So it's okay to do it male or female, and just be smarter about it, because the guys too also are hurting afterwards.
Yeah, exactly.
So
nice.
Beneficial to help with longevity.
Yeah, exactly. One of the other myths about joint replacement surgery that some critics and haters will say is that it's the same procedures. You're doing the same incisions, you're doing the same steps over and over again. What would you say to those, residents or med students who are just like, nah, I'm not doing joints, it's the same procedure?
So the first thing that drew me was outcomes. So what's nice about joints is that's predictable. Because I become really good at them. And what's interesting is I didn't think I was that type of person. I thought I liked huge variety, hence my research, right?
I
like to research in a bunch of different areas. So I like to see variety of things. But if you can do something and perfect it to make a patient walk better, that's one thing. Two, everyone's anatomy is also a little different, right? Just like the lumbar spine, right? A little bit different anatomy, a little bit different areas, and there's different things that you want to place things into the right area. That's the other thing too. And arthroplasty, I find it fun because you can actually, right, left, hip, knee, primary revision.
That's true.
And so I keep the revisions because I think it's important to do the revisions because they are more complex. They make you think and they make you go through different iterations of things. And personally, actually, that's why I like working with residents and students, because that is when you're constantly teaching and constantly on your feet. It's no longer a boring procedure. When I'm walking a resident or a med student through a procedure, I'm telling about every little step, and you can see they're working through the mechanics of it, the how to actually put together a good knee, how to get together a good hit. And you kind of see them take something on paper and make it something real. And I think without that variety, it could get boring, but that's why I like working with students, residents, and fellows as well too.
Awesome. Well done. You did choose academic medicine. Did you ever think about going into private practice, or could you kind of, for our listeners who are kind of, just for review for some of them, what are kind of the pros and cons that you were kind of contemplating when you decided to do your route of academic medicine and, to be able to work with residents and students and such?
So technically the first practice I was part of is private practice, but they call it academics, which is private practice with an academic bent to it. Mine is pure academic medicine, and then there's pure private practice. Each one of them have their pluses and minuses. So for me, I knew I wanted to do research. It's hard to find a practice, especially a private practice, that's going to support research because it's time away from operating, and it's a money sink, right? Whenever I have to hire a research fellow, that's going to take resources. Now, some practices, they highly value that. They say, we want to study, we want to be on the map of research and things like that. So I recognize that a lot of private practices don't do that. So that's why I started with Privatedemics. It was the same place I did my fellowship. And so they kind of had the best of both worlds. When it comes to academic medicine, the benefits of it is I think they value things like research or leadership or committee participation, things like that. So activities outside of the typical seeing patients and operating on patients. So you have interests that fall outside of the academic medicine tends to be a little bit better. That's not always the case though, right? You can still do that in private practice, but in academic medicine, you're also more likely to work with residents, fellows, and students. For some people, that's great. For some people, that's harder. So if you're the type of person who just wants to do all the cases on your own and work with the same physician assistant over and over again, which is good because that gives you a routine, it can be harder to work in academic medicine because of the variety of, residents, students, and fellows who rotate through. So part of it's knowing your own personality. If you want to have that aspect of things. I think there's a financial aspect as well too, although it's starting to blend a little bit more with hospital employment and shit. So if you're a hospital employee, you kind of get a salary. That's more of the traditional academic model. And the private practice model is more eat what you kill, which means you do a case, you get paid for it. But some of academic medicine is turning into that as well too. So the financial models are trying to blend in a little bit more. It's not quite the same when it comes to that. Academic medicine, you have a less tendency from a financial perspective potentially to, let's say, take part ownership in things. So if you had an x-ray system, you may not be able to buy it because that's your hospital's. But you're a private practice, you might go to own it, and we call that ancillary income. And some people like that, and some people don't want to deal with the headache of the business of it. So it kind of depends on what you feel like. I think the biggest differentiators are kind of your support staff who you work with and research-wise.
Nice. Very cool. Well, one of the number one things I did want to discuss with you is WOGO, which I know and you know, but I think I should probably say for the listeners, is the Women Orthopedists Global Outreach Group. Could you describe for our listeners what WOGO is and what it is that you all do?
So WOGO is a group of women surgeons who are coming back from a conference, sitting in an airport lounge and saying, why don't we do our own group where we go out and do joint replacements for free for patients who can't afford it?
Right.
And born literally in an airport lounge with a napkin stained with a little bit of wine, or maybe a lot of wine. Because that's what makes more conversations go well.
Yes, of course.
And a group ahead of us kind of said, this is what we want to do. And so Operation Walk is a well-known group started by Larry Dorr, who did a fantastic job bringing joint replacements to other countries. Again, for most patients who may not be able to afford it. And the idea is to give patients mobility so they can get back to work or taking care of their families or things that they need to do. We're the only arm where we're from multiple different parts of the country and we're all females. So every single surgeon on the team is a female, which is a really nice thing. We just limit ourselves to total knees, and the reason is because we can bring less equipment. If we had to bring equipment for hips and knees, it would exponentially grow our inventory. But we all do total knees and we do all varieties of it. So our last trip was to Cuba in last April, and we did 53 knees, and we also did a distal femoral replacement. So a patient was previously infected from another team. We went back and re-implanted the patient with a distal femoral replacement. So it's nice to have that continuity of care as well too. I think that's something that people talk about when it comes to these outreach, but there's a lot of Operation Walk teams that all kind of work together, which is nice.
Yeah, no, that's phenomenal. So how long have you been a part of WOGO, and like how many different trips have you been able to be a part of?
So I was supposed to take my first trip as a senior resident. We were going to go to Peru. Our equipment was ready to leave from the U.S. over, and they were like, well, you need to pay this extra tax on it, essentially a bribe. And we don't do those with Operation Walk. So a week before the trip, we pulled it, which stunk. The next time I was able to go was to Operation Walk in Congo. It was also the time of my boards.
Oh, no.
Because I wouldn't be able to sit for my boards. That would be a problem. So my first trip was actually last April.
Oh, wow. Phenomenal.
So I've been really involved for a long time, but finally involved as of last April.
Right. Have you been able to kind of just develop, I'm just assuming the relationships that you're able to develop with your fellow surgeons is just something that you guys are going to be able to have for the rest of your careers?
It's fantastic. So that first person I told you about, Dr. Audrey Toe, my first female mentor, I would say, is on these trips. So she's the one who pulled me into this, which has been great. That's part of the mentorship, which is fantastic. And there's a whole bunch of them who are fantastic, who we've all we bond together with the common goal, of improving our patients. And we happen to be female, and that's kind of nice. We don't just operate on female patients, but we do preferentially try to select females especially if they're a breadwinner of their family, and that her not being able to walk means she can't work. That also becomes a problem. But we work together as a team, which is really nice. And I have some pretty strong females who are great role models and also mentors in my life.
Oh, that's phenomenal. I think what a lot of people kind of assume with these mission trips is that you guys just kind of grab everything and then head on over. So I was hoping that you can kind of describe the process of we want to do, this outreach project 7 months from now or 9 months from now. If you can kind of describe what it is that actually goes into a global outreach trip to a developing country.
It's a lot of work. It's way more work than I expected, in all honesty. So what happens is a year or two in advance. So we do it every 2 years.
Wow.
So up to 2 years in advance, we have to find a place. Location is dependent on a few things. One, we want to go back to Congo because we've been there before, and we want to see those patients again and also treat new patients, as well as teaching the team there how to do joint replacements, because it was the first time they ever got joint replacements. But the safety of a country and the safety of the environment at the time makes a big difference. So right now there's Ebola and political unrest. We couldn't go back to Congo. So we reached out to Operation Walk and say, what sites need to be visited? Where else needs to be done? So selecting a site is the first big step that can take up to 6 months to select a site.
Wow.
Once we get a site, yeah, it can take a while. Once we get a site, we need to also do some reconnaissance. Do they have a need? Do they have resources? Do they have surgeons on the ground in case we need, there's follow-up for patients and things like that. And then there's resources. So what we do is we keep our resources in one area, and then we actually have to go and ask for donations to fill them every single time we take a trip. We bring everything with us. So we bring surgical masks, we bring the instruments, we bring all the drapes, we bring sterile gloves, we bring anesthesia equipment, we bring medications, we bring all those things that we don't really think about in the hospital. We just go and grab it. Think of back to latex gloves, right? We don't
yeah, you just throw those. Yes.
And then booties on the, for our shoes and stuff like that. So we bring everything. And we have to get it on inventory. We have to check our inventory we have existing. What else do we need? We need to go through all the drugs to see what's expired, what's not expired, what we need to ask for. So we actually go to a bunch of different companies and ask them for donations. And some companies will say yes, and some companies will say no. And so if one person says no, we have to go to the next company and the next company. So it's a lot of asking, obviously in the good name of helping patients, but it is a lot of back and forth what that goes into that. And then getting the inventory into one place, getting out in a package, and then shipping the whole cargo over. And then getting cargo back, which is also another fun one. And then we do a pre-trip. So actually our team just came back from a pre-trip in Bolivia and get the lay of the land, meet with the hospital, see patient x-rays. We screen patients ahead of time and then screen them again once we're there and make sure they're still healthy enough to undergo surgery. We get their x-rays so we know what parts to order. So Zimmer's been our constant sponsor. They're fantastic. They donate all the implants, but they're not going to bring everything that's available in the hospital, right? We're going to bring a certain amount based on what we think from the x-rays, get them ready and go. And the question is it enough or not? But we just kind of go from past experience and what we need to bring. Right. So it's a lot. And then one team comes in a little bit in advance. So let's say everyone else is getting there on Friday, they get there on a Tuesday, set everything up, set up the ORs like we would set up our ORs at home and set up the clinic and injections and things like that, and then run it like we would at home.
Wow.
It's a lot of work, but it's a lot of fun.
Yeah, that just sounds amazing, and kind of stresses the importance of preoperative templating for us residents. So certainly.
It's also so important.
Yes, exactly. I was wondering if we can talk about some critics of global health initiatives. Will kind of throw shade on these quote unquote mission trips in the sense that you go over, you bring all of your supplies. And oftentimes this requires a lot of time and resources from everybody involved. The post-op follow-up for these patients is often left to the local providers. Sometimes it can be difficult to track the clinical outcomes of the patients that are operated on. And there's often not as much emphasis on educating the local providers on how to kind of help with the orthopedic surgery itself. And so I was wondering if you can kind of talk to some of the criticisms that often surround global health.
So that's a big problem. Definitely why we try to use places that have previously had operation walks and will follow with other operation walks teams. So the idea is it's continuity of people who also do arthroplasty. So let's say we operate in Bolivia. That's a common place for operation walk teams to go. A few months after we go, another operation walk team will go. So it's not just stuck to the local area. And that's what's nice about going through a global organization like Operation Walk. We work together to make sure that we don't do that. Right. Because that's the worst thing to do for our patients. Another thing too, let's say we had a patient in Congo and they no one's going over there to unfortunately operate on them. So we actually brought the patient and flew them over to the States when they had a complication. Right. So, it happened months and months later, but still something that we feel responsible for. So we raised the funds, did everything like that to set the patient up. And then finally, what we can do too is teach the local surgeons. So one of my friends, he's at Penn. He's actually going to open up a hospital in Tanzania. Oh, wow. And in Tanzania, what he's going to do is he's going to have teams come in for 2-week blocks at a time, back to back to clean up stuff that happened or any leftover patients that need surgery. So that way, and teach all the local residents and attendings there too, which would be a benefit as well.
Wow, that's phenomenal. So you were able to get involved into global health. What would you say for other orthopedic surgeons or orthopedic surgeons in training who want to get involved in global outreach?
So the first thing I would say is I would highly encourage everyone to at least experience it once in your life. And I think what happens in America, appropriately so probably, is we're used to, fast food or Netflix or getting what we want at a turn of a dime, right? I need surgery, I should get surgery. patients who are in other countries are incredibly grateful for what they don't have and then what they get. So just to see that, I think that we all said it too, is when that patient who hasn't walked in years, decades, takes their first step, it's the most amazing thing in the world. So, and I think that reminds us why we went to medicine in the first place. I think a lot of us get tied into medicine and say, medicine is great because you can pay off your loans, or it's things like that. We miss the bigger picture of medicine, and I think a lot of times if you ask a student why they went to medicine in the first place, like, we want to help people.
Right.
Well, right, we forget those, I think, by regular daily practice. So being able to do so is seeing patients who are really grateful, and grateful that you can give back in a way with your skills that is very meaningful to someone else.
Yes. I was fortunate enough to do a trip with Operation Walk to Nicaragua, and that is literally the exact thought process that I had after that trip, is that I did it right after that I had matched, and it was this absolutely beautiful thing in which I realized, oh yes, this is why I went into medicine, because I think especially right after the match, I was so concerned about what residency program am I going to, like worried about test scores, worried about all these sorts of things, and it was such a humbling experience, because it really does bring you back to why it is that we all kind of decided to become surgeons and physicians and helping people. So that was just, I totally agree with you there. I do want to talk about we are surgeons, and so I do want to talk about how it is that you perfect your craft as an orthopedic surgeon. Do you have any skills or processes that you do in order to make sure that you are perfecting your skills as a surgeon?
So a few things. So I can talk about arthroplasty, but I have to admit that if I did arthroscopy, I'd probably play video games. I don't do arthroscopy as much, so I don't have to play video games. From an arthroplasty perspective, I think as an attending, one thing that I forget is that I can learn from others, right? At this point in time in my career, and I'm young in my career, I could be like, well, what I do is right, so I should probably stick to it. And that's not the case. There's so much that you can learn from other people. So at my stage in my career, what I think is really interesting are things like traveling fellowships, where you can watch people operate and learn from them, or going to courses and meetings where people talk about different techniques, different tips and tricks, which are actually useful, or cadaver courses, or different areas where I can still learn from things. So I might go teach a course, but I actually can learn from the other people who are teaching other people.
Right.
The other thing as a resident, I think, is try to rotate with as many people as possible. I think some people get a good reputation and you want to operate with them more because they let you do more, which is a great thing.
Right.
But there's also still a lot of benefit to learning from someone who you're operating with, and maybe you're not doing as much, but you can learn tips and tricks from them. And I'll tell you, some of the tips and tricks I learned are actually from different specialties.
Wow.
Right? So I remember as a resident, I was like, oh, my shoulder guy used to do this, or my, foot and ankle colleague used to do that. And I was like, oh, I can use that in my practice. So I think the key as any surgeon, and goes back to your question about being a joint surgeon and being bored with right or left or hip and knee and primary vision, right? Is we can still improve our craft. We can still learn. We can still pick up things. And I've seen some surgeons who have been in practice for 20 years switch to a different surgical approach, because they think their patients will do better. Right. So if they're doing it in the name of patient care and they do it appropriately, they start with cadaver courses, they shadow someone, they watch someone, and they have someone proctor them, and they get through the whole learning curve with other people helping them. That's a beneficial thing. So as long as you keep doing it for patient care and not for other reasons, then that matters.
Oh, well done. Awesome. This is a podcast that hopes to, highlight women in orthopedic surgery, and was inspired because of the fact of the lack of gender diversity that is in our field. So I was wondering if we could take a moment to just kind of talk about the lack of gender diversity and kind of what your outlook is. And do you think that there's anything that we should be doing in our field to kind of help increase, I know that's a very broad question, but to help increase the gender diversity in our field?
The good news is you ask 10 people this, you'll get 10 different answers.
Yeah.
So there's a bunch of different ways to skin a cat. And I think the thing that means the most to me is when women aren't looked at as women, for lack of a better term. And what I mean by this is I was walking with a mentor once, and my mentor said to me, I don't think there's any differences between men and women in orthopedics. And I go, really? Because if I have dinner with you one-on-one, people will think we're having an affair.
Yeah.
But if a dinner with a guy one-on-one, you're two guys going out for dinner. And that's not fair.
Right.
And to be fair with this whole Me Too movement, I have guys who said, I don't feel comfortable going out with a woman one-on-one because of the optics of it, or, you know, how she'll perceive it. Versus if it were truly gender neutral, doesn't matter who you have dinner with, or lunch with, or breakfast with, right? That you should be able to have dinner one-on-one with anyone and have it be about business.
Right.
So that's what I love to see where the field goes. Where that needs to come from is probably a lot of different changes ahead of that.
Yeah.
And that's what I love to see is gender neutral, you know, and that means gender diversity. You take someone because they're good, not because they're male, female, orange, purple, green, whatever.
Right.
They're good at what they do, you know? And I think they're starting to recognize that, you know, women can do just as good of a job as men in orthopedics, for example. So I think those tides are changing. And I think the idea really to do it is by just opening people's eyes to it.
Right.
You know, like for some guys, it has to be, it's okay that you go to lunch with your female colleague and it's not awkward, right? Because she's just one of the guys. And then from other guys, it's like, okay, you need to tone down some things so that it's appropriate to hang out. And it just depends on the person, you know? And the same thing with women too, on both sides of things. So I think trying to take the big term that people are talking about now are implicit biases, bring them to light, and then recognizing them and addressing them. So if I may feel implicitly biased that if I have dinner one-on-one with a guy that I feel that is, you know, derogatory towards me or something like that, then that's something I need to work on, right? We're equals and it's okay. And I think if we all work on that ourselves with training and things like that, that can actually improve our field as well as all other fields, but especially in orthopedics. I will say for one thing though, in arthroplasty, because there's so few females, whenever I go to a meeting, there's no line for the bathroom.
Exactly. Isn't that the best things about ortho is just you go into these conferences and you're just like, oh my gosh, the one time in my life where I don't have to wait at the bathroom.
But I don't mind if we have gender equality in orthopedic where I will have to wait in line for the bathroom.
Yes, exactly. I'm willing to make that sacrifice.
I am willing to take that for the team.
Oh my gosh, that's so true. I was hoping... It's interesting that you talk about the implicit bias talk because I've heard this kind of for the past couple months. I think people have started to have this in the conversation, and it's almost, I feel like, this chicken and egg sort of thing where like which came first, in the sense that in order to have people see that there are these implicit biases, you need to have more women, and you need to have more women being vocal. And at the same time, in order for there to be more women and to have these women be more vocal, you need the recognition of the implicit biases. And so I think it's very interesting, the situation that we're in, because it's like we kind of need one with the other, and yet we need the other with the one. And so I don't know if you have any comments on that.
So one thing I will add actually in terms of how can we move our field forward in terms of gender diversity is having men recognize it.
Yeah.
And it'd be great to have all female cheerleaders, but it's, as you said, it's very hard to when we're so few of us in the field of orthopedics. I think what I'm very impressed with that a lot of men are taking up the banner. Some men are being champions. A lot of my mentors were men, right? And they supported me because maybe in spite of us a woman, because of a woman, I don't know, but they supported me for me. And more men need to do that, raise women to leadership positions, raise recognition for a woman, raise the flag, and that'll help our cause in ways that it's helped many other causes throughout the nation, right? Let's say racial diversity. It's not just, that racial group standing up for themselves. It's other groups also supporting them, saying this is a plight. And I think they're starting to do that in orthopedics. I think more and more men are starting to take on that banner. Some don't want to, and I get that, but some are really willing to. And as we get more people on our side, for lack of a better term, that tends to help, one, raise awareness of the biases and also kind of erase some of the biases. If they see someone, hey, that guy's supporting that woman, she must be pretty good. And then all of a sudden it becomes like she's good, not that she's a woman.
I know. Yes. I totally agree with you, because I feel when you actually look at like the percentages, there's less than 10% of women. There's 90% of men. If we're only using the 10% of women that we have to increase the number of women, this is going to be a very, very long process before we actually get to that level of gender diversity. And so I think utilizing some of that 90% might actually help make this process go a little bit faster. And I know that I really do appreciate you taking the time out of your busy schedule to talk with me. So I do want to get into my last 6 questions that I have for you. And these are the questions I'm going to ask every guest on our show. And so my first question is, what is your favorite procedure to perform and why?
My favorite is a total knee replacement. It sounds so easy, but I love that it's exposure, and there's so many different ways you can tweak it. And so as a resident, you learn about gap balancing, and if you cut more distal femur, you get this. If you cut more posterior flexion, if you increase the size, it's tinkering. Right. And if you tinker it right, you get a perfect knee. And that perfect knee allows a patient to walk again. So from a technical perspective, I love total knee, and I love patients after surgery. Now, my total hip patients do better, just because total hip patients always do better.
Right.
I do like the technical aspects of total knee.
Awesome. What are your go-to topics for grand round presentations?
So when I was a first-year resident, I was interested in doing some sort of research because everyone did research, right? So I went to my mentor who had ended up becoming a mentor, and I go, I'd like to do a project. So he gave me a project that was called the Pittsburgh Experience Infections. And I was like, how do you publish something called the Pittsburgh Experience? The answer is you don't. But I started doing research on infections. And ever since, infections has been my absolute go-to topic for every single talk that I've given just about.
Oh, awesome. I know congratulations on your paper in JBJI. That was a great read. So congratulations on that. Yes, of course. What is your favorite memory as an orthopedic surgeon?
So my favorite memory probably was two of them. One is when I first saw my first joint replacement. And I looked at the tool. I grew up with a sister, and I didn't use power tools and stuff like that, but I was the one assembling the IKEA furniture. I mean, it wasn't fancy or sophisticated. It was, me and a screwdriver essentially and a hammer, right? And I walked into the operating room, and it was like saw blades and hammers and jigs, and I was like, this is so cool. And I'm not a mechanically inclined person. I loved it. So that was my first thing. And the second thing is I remember going to my first Hip and Knee Society, American Association of Hip and Knee Surgeons meeting. And when I went there, I was introduced to someone who happened to have a classification named after him. Ooh. And so I go, you are that person? And to finally meet someone who's so famous in your mind, right? Because you've used classification and learned a classification, actually meet them in the flesh. It was the most embarrassing moment of my life. Yet one of the most memorable, because you're a real person. And they were a great normal person too. So it's very cool to see that.
Oh, that's phenomenal. What are your favorite activities outside of the operating room and outside of medicine that you enjoy to do?
What's that? No, I'm just kidding.
I know exactly right. She's like, what is that?
I don't understand. My absolute favorite thing to do in my free time is to play with my 4-pound dog, Lily. Aww. Lily is a Yorkshire Terrier. She's not supposed to be 4 pounds. She's supposed to be a lot bigger than that, but she doesn't like to eat. Oh. So I'm with her.
Oh, that's adorable. When did you get her?
I got her in 2016. She just turned 3 yesterday, actually.
Oh my! Did you have a birthday party?
Well, she doesn't understand. I gave her a treat, and she was very happy.
Oh, good. What are your future goals and projects? I know you have a lot of going on, but in terms of what are the next steps that you're hoping to make in your career?
The funny thing, I think, is the first time in my career where you don't know what the next step really is, in all honesty. I think from a research perspective, for example, I'd love to be able to do a big prospective randomized controlled trial across many institutions that hopefully changes our practice. And I'm looking into doing so in infection and antibiotic duration, because we're not sure about how much to give our antibiotics for. Patients come in for 7 days, for 10 days, for 2 weeks. And so that's one big area that has not been established yet. So that's what I would like to do. One of the things from a research perspective. From a clinical perspective, obviously continue taking good care of patients. From a leadership perspective, right now I'm in my institution right now. I'm director of clinical research for Arthroplasty services. Great. Whether or not it turns into something else, like my mentors have done before me, are also good opportunities, whether it be department leadership and society leadership, either Hip and Knee Society or AAOS or AOA. Those are all things to be determined, but things that I think I aspire for.
Phenomenal. And my last question for you is, what advice do you have for female orthopedic surgeons and female orthopedic surgeons in training?
So my best advice, I would say, is to lean on each other. And I think that we're taught as female orthopedic surgeons to be strong, independent, and do it yourself. That's not what the guys do. The guys show each other's cases, show each other's complications, ask each other's questions, build each other up, bring each other up. And they do that for women as well too. But women aren't as good at that routinely as men are. And so I think this generation of women, we're doing that to one another. We recommend each other for things. We invite each other to things. So support each other. Don't see each other as competition. See each other as building the next best thing in orthopedics.
Awesome. Well, thank you so much for your time, Dr. Chen. I know you're very busy, and congratulations on everything that you've done. And I really hope you the best of luck with, your future endeavors. Thank you so much. I hope everyone enjoyed this episode of the She Can Fix It podcast with Dr. Antonia Chen. And we hope to bring you more great interviews on the She Can Fix It podcast. Please subscribe to our podcast on Apple Podcasts, Spotify, Stitcher, Google Play, or YouTube. You can also find us on the web at shecanfixitpod.com. We are also on Twitter and Instagram at shecanfixitpod. References for this podcast include an article for which Dr. Chen was a senior author on. The article is entitled Perioperative Antibiotic Prophylaxis in Total Joint Arthroplasty, a Systematic Review and Meta-Analysis. This article was published in JBJI in May 2019. Finally, I want to say thank you to all of you, all the listeners who are taking the time to listen to this podcast. Please subscribe to wherever you listen to your podcasts. Also, please spread the word. Tell your friends, your mentors, your medical students. If you have any questions or would like to hear a friend, mentor, or legend on this podcast, please feel free to email us at shecanfixitpod@gmail.com. I would like to take a moment to thank those who helped to make this podcast possible. A sincere thank you to Dr. Mary O'Connor for her mentorship in creating this podcast. Thank you to the amazing attendings here at Yale. Dr. Carrie Swigart, Dr. Adrian Sochi, Dr. Elizabeth Gardner, and Dr. Andy Halim for being exemplary role models for us. And finally, many, many thanks to my editor and co-producer, Andrea Van Kirk, without whom this podcast could not be possible.